Hello, this FERNE educational video discusses the care of emergency department patients with dizziness and vertigo in an attempt to successfully diagnose and treat serious central etiologies. No lecture would be complete with talking a little bit about our EMR documentation. My name is Ed Sloan from FERNE.org. More to follow on FERNE later. So, dizziness and vertigo patient, EMR documentation in the ED. There are 3 dot phrases we need to pay attention to. One for dizziness. Here's what it might say. Diagnosis, nonspecific dizziness. No evidence of syncope or near syncope. No findings consistent with vertigo. No motion symptoms noted. No physical exam or test findings demonstrated a systemic cause to the symptoms. Normal cardiovascular exam. Neurological exam including vision, hearing, speech, standing and gait, cerebellar signs, and hint testing is normal. Patient not orthostatic. Vital signs normal. EKG and lab testing normal. Able to be discharged safely. Patient aware and agrees with plan for outpatient follow-up. Return as needed. What would a vertigo dot phrase look like? Vertigo, diagnosis, acute vestibular syndrome, AVS. Patient with motion symptoms consistent with vertigo. Specific neurological exam. No evidence of syncope or near syncope. No physical exam or test findings demonstrating a systemic cause of the symptoms. Normal ENT and cardiovascular exam. No vascular abnormalities noted. Normal neurological exam including vision, hearing, speech, standing gait, and cerebellar signs. All were normal. Patient not orthostatic. Vital signs normal. EKG and lab testing normal. Patient able to be discharged safely. Patient aware and agrees with plan for outpatient follow-up. Return as needed. Now, what might a HINTS positive or HINTS plus dot phrase look like? Diagnosis, acute vestibular syndrome, AVS. Likely acute vestibular neuritis, a peripheral etiology. What might the HINTS plus documentation look like? No unprovoked vertical, torsional, or bilateral fast nystagmus. No vertical skew correction. Head impulse test demonstrates correcting saccade left, consistent with left vestibular system dysfunction. Remembering that a noted finding of correcting saccade suggests a peripheral etaology. An absence of a correcting saccade on both sides would suggest a central etiology. No facial or extremity weakness. No limb ataxia, dysarthria, speech abnormality, hearing loss. No pain or temperature sensory loss. Note that this is more than just light touch. No diplopia, ptosis, anisocoria, or dim vision. No truncal ataxia and cart, and no ataxic gait. Patient able to stand and walk without assistance. So, our EMR plan is the vertical central. Have a neurological exam template. Have a neuro exam for vertigo patients. Template the HINTS plus exam. Have dot phrases for our decision making, the ones we just reviewed. Be able to document functioning, the patient can walk. Have your discharge instruction templated. And know that your documentation will indeed enhance patient outcomes by keying you to remember to do all of the things related to dizziness and vertigo that could be central in acute vestibular syndrome patients. As I said, my name is Ed Sloan. I'm FERNE President and Board Chair. I have no financial conflicts. Please go to our FERNE.org website and our YouTube channel for more content related to the optimal care of the patient with dizziness and vertigo. Follow us on social media for more real-time information on the care of all patients with neurological illnesses, injuries, and emergencies, FERNE.org. If you have any comments or questions about this video lecture or all of the lectures related to the care of the ED patient with dizziness and vertigo, please email us at fern.org@gmail.com. Thank you very much and have a good day.